Hello, thanks for your attention so early in the morning. Thanks for the invitation also with Chappie. I actually had an extra 5 minutes, so I'm actually going to squeeze two topics into just to make it a bit interesting for you. So I'm sure you've heard this all the time, this revolution, and I'm probably in number 15 or 16 that sort of talks about this. But what we're doing now in endoscopy is so radically different, and we would have not hoped actually to do all these things many, many years ago. So we can now actually just completely remove large cancer in one piece, all from the inside. Patient doesn't need an operation. They're done in an hour. We've got fast recovery time. We can now endoscopically treat reflux. We can make full thickness cuts if we make a perforation. That used to be a big deal. But these days, we just perforate. That's fine. We just go in, remove the cancer, put a little clip and a little suture in there. I do a lot of infected necrosis, and these patients, 25% of them used to die because we couldn't open them. They ended up with horrible open abdomens in ICU. These days, we'd all do it endoscopically, and after 50 patients have done, nobody has died and everybody got better. We're now talking about incurative pancreatic cancer now being cured if we just inject a bit of radiotherapy into the cancer itself. And the two topics I'm going to talk about today is really just endoscopic bypass, what we can do for cancer patients. And also, I'm just going to squeeze in the first prevention trial for pancreatitis, which I'm really excited about, that's starting later this year. So just to show you what's happening here, this is actually Cameron Chow, one of my really good friends and colleagues, actually sent me this on Friday, and he was too polite to send it to anybody else. So this is full circumferential endoscopic removal of the top layer. So a patient had an early cancer with lots of irregularities around it. He just chopped the whole mucosa layer out in one piece, leave the muscle layer behind, new layer overgrow it, and the patient's fine, doesn't need an operation. So these are all the crazy things we're doing these days. So quite often when I'm talking to my patients, I always feel like this, that we're saying, look, our normal equipment is down, I'm just using a tapeworm with a GoPro on it. And the thing is, the more of these cases you do, the crazier requests you get from the surgeons where they go, I've got Mrs. on the ward, she's been in for 6 weeks. It's a really unusual problem, can you sort of fix that? And then I have to have a chat with the patient saying, look, I don't know if anybody's ever done this before, but I think it will work. And the reason for that is we've got so much more improved equipment, so many more better techniques, and it's all less invasive. So my anaesthetists hate me because the patient's not fit for a big operation, but a 30-minute endoscopy is usually pretty good, so I'm making my anaesthetist much more stressed. The other thing is we're getting much more complicated patients, altered anatomy. Lots of people have had now weight loss surgery and they can't get to the excess areas anymore. And the main thing is that every patient has a unique problem, and there is not a randomized trial that I can sort of quote, so then it just really comes down to a complicated consent process with the patient. And this is really my greatest satisfaction in my life, where I can actually help these patients that are in a quite dire situation. Although if you ask my wife, it's the one thing she will hate, because this is all late at night and in the weekends. So what we've got what's called an endoscopic rivet tool. So I can staple any two organs together that are within 1 centimeter of each other. If you look at all the studies, they all say 95% success rate, 5% minimal, minor, a little bit of bleeding, a bit of infection sometimes, and they all come down to quality of life is improved, reduced hospital stay, cost, and all of these solutions can be permanent if they're not really surgical candidates. And really the possibilities are limitless. I've done all of these things. So stomach to pancreas, stomach to gallbladder, duodenum to gallbladder, duodenum to bile duct, stomach to intestine, intestine to intestine, stomach remnant to pouch. So all of these things, as long as they're within 1 centimeter, I can connect to. So when it comes down to what we call gastrojejunostomy, so and a bypass, what we have, these are patients usually with a duodenal, pancreatic, or a stomach malignancy. The cancer has grown so much that it's completely blocking it off, and people are vomiting, unable to eat. These patients have really poor outcomes. They normally are really bad surgical candidates because everything is completely scarred up with cancer in the abdomen, and quite often the surgeon can't even get there. So what we used to do is put a nasogastric in and send them to a hospice to die slowly because of starvation. We've now got a really nice new, what we call an endoscopic gastric bypass. This usually takes me to between 30 to 60 minutes. The patient can drink immediately afterwards, and I've got them on a soft diet 5 days later. So how does it work? Well, we've got an endoscopic ultrasound. The first thing I do is I put a feeding tube past the blockage into the small intestine, because I can't stick a needle in a deflated target. So if you're trying to puncture a deflated balloon, you're never going to get in. So I've got to swell the balloon up first, and then what I can do is I can find with the ultrasound probe where the area is, puncture it. We've got a hot, like, cystotome, so diathermy in, anchor it in on one side, pull it back, there's another flap on the other side, and that sort of keeps it in place, and then you can get up to 2 centimeters of opening in between. So this is an example of this. This is a patient with a pancreatic cancer. You can see it's completely swollen up, the duodenum, and the patient can't eat. So in the first stage, I'm putting a feeding tube past the blockage. What you can see now, it's going past the blockage up into the jejunum. And then once I do that, I hook that up to a foot pump so I can distend my target. So now I can see the bowel is all inflated with water. I burn in, so you can see that's the little swirls around. And then the first flap is getting deployed to sort of hook and anchor it on the inside. So we can see that slowly deploying there. Then we pull it back until it's in the right spot. And then I balloon dilate it up so it's big enough. And then what you should be able to see in a second is that you can actually see the feeding tube behind it. Now, interestingly, these patients don't really have any pain afterwards. It's like putting in a peg. Like I said, there's an immediate relief of the obstruction. I normally just wait for 5 days until they go on to a normal diet, just to make sure they don't vomit and everything goes well. But this is actually a relatively simple procedure, although my heart rate is always higher than the patient's, because if I stuff up, the patient is really stuffed. So far I'm almost done 20 patients, so 19 patients in total. The 2 exclusion patients are patients that I couldn't get the tube past, although we've got a new solution for that as well. I managed to get the stent in 100% of patients. Almost everybody had a clinical success. One patient had such a distended stomach, by the time it all shrunk down at the bowel, I think it was a little bit twisted, and he vomited after 3 weeks, and then he did an operation. But I've had no bleeding, no leaks, and there was one patient that liked celery, and I've had a few times where I had to fish the celery out from the stent. I'm not sure if you can eat again why you would eat celery, but... So it's really a versatile endoscopic tool. It really adapts to all unique situations, and you can put it basically wherever you can. Minimally invasive, highly technical and clinical success rate, but it's really technically difficult, and it raises my stress level quite well. It's really in the Auckland region. I'm the only one that does these. There's Frank Weilet in Waikato that does these as well, but it's really in very specialized centers. And the main reason for that is I've got really good surgeons backing me up, so I can be quite adventurous because I know a surgeon is there if I need be to bail me out of a situation. So this is really multidisciplinary team meeting where everybody gets involved. I do the procedure, but I can only do that because I've got a team behind me. And again, like really close collaboration. So I'll just show you another example here of all these things we never thought we would be doing. This is a 42-year-old gentleman who had a Rotorua gastric bypass for obesity, slipped the disc, got some anti-inflammatories, and the whole abdomen just exploded. His gastric jejunostomy, had a big ulcer, just abdomen, poo in the abdomen, everything came open. And what we can see at the bottom here, sorry, it's a little bit slow, his whole abdomen was completely open. So you can actually see the bowel, they couldn't close it, there was pus everywhere. And then what ended up happening is this whole limb, so was completely missing. So he had a disconnected stomach, so whenever he swallowed, he would just vomit up his saliva, and there was actually no way to actually get the gut going. And then he had a feeding tube in his old stomach sitting where they just fed him a little bit. The surgeon said, there's no way we can ever go back into his abdomen, and the guy was just saying, look, I'm just stuffed, I can't really do anything. So then what we did is we said, great, I'll just use one of my new rivet tools. So this is the drainage tube that he had in. You can see the stomach goes nowhere, it's completely closed over. I distend the stomach with water, and I find the old stomach, and I put one of these stents in, and then I connect the old stomach to the new stomach. go. So once we see the black marker, we know in the right spot. That's one of the internal ways we can make sure the stent is in the correct position, that we don't deploy it too far in or too far out. And then we do the same thing, we dilate it up and we can actually see the old stomach in between. Sometimes a little bit fiddly. There you go. And the same thing, balloon, stretch it up, and you can actually see that's the stomach, and we actually reconnected the stomach. He can say, I can only have a little bit of liquids, can't really eat very much, and then we actually end up putting a second stent in. I'll just skip through there. We're publishing it hopefully shortly. But with Cameron, my good friend, we actually cut the whole stomach and we'll layer, so 2 stomachs, both full thickness cuts, and we just suture it up on the inside, and the patient can actually now just have a normal diet. So I'll move on to my second topic. Can we actually prevent pancreatic cancer? Big study in the States that came out saying, oh, look, we're doing amazing. Cancer deaths are down 30%. So we can say, look, 250 deaths per 100,000 in 91. Now we've dropped that to 140. Everything is amazing. Look at how great we're doing. You look at pancreatic cancer, you're stuffed. Basically, 12% survival and 5-year survival, and basically nothing's really changing. The other thing is what we can see in all these cancers, pancreatic cancer, cholangiocarcinoma, the incidence actually is going up every year, and there is currently nothing we can do. There's no intervention, no screening program. And then when you look at the cancer deaths, at the moment, the pancreatic cancer actually has taken over most cancer deaths from all the other cancers. So more than colorectal, more than breast, more than prostate. And the reason for that is we find it late, there's usually no treatments, and the incidence is all going up. So this is all pretty grim. So like I said, everything's got some sort of fancy screening, skin cancer, Barrett's esophagus, breast cancer, whatever you're looking at, we're finding that cancer development is a very slow process, takes 5 or 10 years. You got chronic inflammation, whether it's a virus or something else, and then you sort of get slow cancer progression, and we're finding things early. But for pancreas, we really got nothing. So what we think is that all of these cysts, same thing as anything else, with all these sort of fancy pathways, you get a nothing, an adenoma, then it gets a bit more irregular, dysplasia, then you get a cancer inside the dysplastic area, and then the cancer spreads. So with regards to cysts, you can see it's clean, the wall gets thick, and then you've got a lump sitting in it. And then I'm sure you've had this all the time, you find somebody's got a bit of pain or some abnormal liver function test, you do an ultrasound or a CT, and it comes back with there's a cyst in the pancreas. Really common, depending on what sort of age group you're looking at, it's up to 20%. And we think that these, what we call mucinous cysts, are probably responsible for up to 30% of cancers. So it's not all of them come from a cyst, sometimes they come from solid, but it's still pretty abysmal. So if I had a pancreatic cyst, if it's low risk, it's a 7% risk of getting cancer in 10 years. If it's a high risk, 1 out of 4 people will end up with pancreatic cancer, and that's the reason why we end up doing so many MRIs. So I looked around and actually found almost 1,500 patients in my region that actually had RPNMs. We have a large burden, and the most depressing thing about the multidisciplinary team meetings that I do is we are watching people develop cancer slowly. So we say, oh, the cyst is a little bit bigger, she's 70 or 80, she's got a bit of COPD, we don't want to do a Whipple's, why don't we just do another CT? And then a year later we say, oh, oops, actually it's a cancer, we can't really do anything. And the reason for that is that Whipple's, 1 out of 50 people die, and 1 out of 3 has like major leaks or major complications and spends months in hospital. And then even more depressing is that when we look at the statistics here in New Zealand with pancreatic cancer, 50% higher risk of incidence cancer for MARI, and then when they do get cancer, quite often they've got multiple comorbidities and they actually have much worse outcome. So 30% higher death rate with pancreatic cancer in MARI when you compare them to non. So we really must do something to sort of stop this horrible condition. So just to show you what a Whipple's looks like, they basically take out the gallbladder, the duodenum, the head of the pancreas, and they replumb everything. Cost about $100,000, and like I said, it's pretty grim. So what we're doing here now, I'm pretty excited. This is I think the first Australasian trial of this, is where we can endoscopically ultrasound, put some chemotherapy into the cyst and shrink it and get rid of the cyst and actually stop this early and stop cancer progression. Nobody dies, 5% of people can get a bit of abdominal pain, and it costs about $4,000. So it's not new. People have been doing it for a little while, since 2005. They've been trying putting in alcohol, like they're doing in livers and all sorts of things to ablate it. But the problem is, if alcohol gets into the pancreas, you don't really want to mess around with alcohol inside the pancreatic duct and end up getting horrible pancreatitis, and it didn't really work. But these days we've got really good chemotherapy specific for pancreatic cancer. So now we've actually got a good trial, which is called the CHARM. They injected no alcohol, but 2 chemotherapies into the cyst. And what we can see here is that they had really strict criteria for complete remission, and 70% of people, the cyst completely disappeared, and this is long term. Of the follow-up studies, nobody got cancer. So, like I said, I'm really excited to get a Gut Foundation grant to do this. It's a single-arm phase 2 study, and we're recruiting 20 patients from Auckland, Northland, and Waikato. And what we're looking is for people that have got a mucinous cyst greater than 3 centimeters, or that we're really concerned and it's slightly smaller but growing really, really quickly. We can't do this for pancreatic cancer yet, or if we can't really stick a needle in it, or if the cyst is really sort of mainly in the main duct. So what we'll do is we'll go in endoscopically ultrasound. It's actually a really simple procedure. We stick a needle in it, we suck the fluid out. We routinely do this, but then rather than only sucking the fluid out, we're going to put gemcitabine and Baxatel back in the chemotherapy. They can go home the same day. The procedure takes about 15 minutes. Get a blood test and then an MRI scan after 3 months. And like I said, we've got pretty strict guidelines compared to the rest of the regional studies, where we're saying it's complete response if 95% of the cyst is gone. And we're doing some fancy genetic sequencing as well with the university, so this is quite exciting. So really excited. So it's me doing it, and we've got Frank Willett in Waikato. It's great to have him on board as well. And this will hopefully be the first step in actually trying to prevent pancreatic cancer in patients in high risk, and will hopefully be really a new step. And once we've got this established, hopefully we can then do this as routine treatment for patients. So really big thank you to the Gut Cancer Foundation for really sponsoring innovative research, really getting newest treatments in for patients. So the nice thing is we've got 20 patients in here. If we pick the high-risk group, out of those 20 patients, we can probably save 5 patients from getting pancreatic cancer. So I'm really excited about all of this. Thank you for all of your attention.